anesthesia enthusiasts, and welcome to this month's episode of Style Points. I'm your host, John Crow. Today, we're talking to my friend and colleague, Dr. Brad Budde, who directs the Regional Anesthesia and Acute Pain Fellowship here at the University of Cincinnati. We'll talk about his perspective on pain management and the philosophy behind it. We don't have an RSI for you this month, so let's jump right in. So what was your radio experience like in college?
It was interesting because it was like a full studio. So I had no idea what any of the stuff was doing, but our one buddy did. And so we were just talking sports, and we had the Sunday evening time slot, which rivaled Sopranos. So,
yeah.
So we got to, I think we got up to 41 listeners at one point.
41.
Which was good. The highest number of listeners for any show on Miami Student Radio, which is saying something about who we were broadcasting to.
Miami Student Radio.
Yeah.
What was the call sign?
I don't remember.
Oh, come on.
The name of our show is Crunch Time. I remember that. But other than that, I don't remember much about it.
Well, loyal listeners, welcome back to Crunch Time with Brad Budde.
We would do trivia, and we'd all be like 4 of us would be really into it, and people in the air, our buddies are texting us like, "Stop! No one cares about this." But we're having fun. That's all that matters.
Well, people text me all the time that they don't care about what I'm doing. So
yeah, you have kids. They never care what you're doing, unless you're doing exactly what they tell you to do. But
that's great. Brad, thank you so much for joining us.
Thanks for having me.
So we have a lot to talk about in the world of regional anesthesia, but before we do that, I wonder if you could tell us a little bit about yourself, what your interests are, and what we're here to talk about.
Well, yeah, so my name is Brad Budde. I'm an associate professor here at the University of Cincinnati in anesthesia, and my main interests right now lie with my family. I'm married and have 2 young boys, 5 and 3 years old, so they keep me pretty busy. I've always had a interest and passion for sports, so I like watching sports, playing sports, mostly golf these days, and then I have my career, which has been mostly dedicated to regional anesthesia and acute pain medicine. So much so that I've started my own fellowship and run my own division, and really enjoy doing it.
So why regional anesthesia? What's so interesting about that?
So it's a little bit of a longer story, but it goes back to my interest in sports. So when I was young, really liked playing sports with my friends, and I was actually over at a friend's house, and his dad actually happened to be an orthopedic surgeon, a sports surgeon. So we were in their basement. They had all this sports stuff, and my young brain said, "Wow, if I'm an orthopedic surgeon, I can have all this sports stuff in my house." I'm like, I really want that. Found out later that he actually played on a national championship team for University of Louisville basketball, which is why he had that stuff.
That also...
but it still piqued the interest. So I was so interested in sports that I finished college, and I didn't go right into medical school. I went and got a master's in sports studies at Miami University, thinking about going into potentially coaching or athletic administration. And there's still something about that draw to orthopedic surgery and medicine and kind of a sports surgeon that I really couldn't let go. So I applied and got into medical school, and I came in so tunnel vision. All I cared about was orthopedics until match day came, and I didn't match into orthopedics.
Oh, wow.
Then I had to kind of go, this whole drive and passion is kind of a lot harder than I was anticipating. So it actually was my April of my 4th year of medical school where I did my anesthesia rotation. And at the time, even though I didn't match, I told everyone, I'm doing orthopedics. I'm going to do it. Oh. And so the anesthesiologist that I was fortunate enough to rotate with here at University of Cincinnati, as well as some of our community hospitals, took my passion for orthopedics and said, look what we can do to help the orthopedic surgeons, and showed me nerve blocks, regional anesthesia. And I had no idea. I'm like, this is really cool. And that really kind of spiked the interest there. Then when I was doing my preliminary intern year at Penn State, I got to see and experience a little bit more of anesthesia and regional anesthesia. So then I said, this is kind of more of my passion and interest. I want to go into this and be in anesthesia. And then once I got to Rush, where I did my residency, our regional anesthesia director there, her and I really connected, and I learned a lot from her, and kind of really just drove that passion forward about how I could use this interest in sports, but to also help kind of that patient population but then expand that out to, wow, I could actually help a bigger group of people than just athletes with this. And so that's what kind of led me to where I am now.
It's so interesting that this podcast makes it much easier for me to have these conversations with people, because I find all this really interesting to find out about you for the first time, because I never knew any of that. But I don't know that I would have ever asked you just in casual conversation.
Yet we've known each other for 8 years now.
Yeah, right.
And this is, like, you don't ever tell people about the whole story of how you got here, right? And, it's kind of interesting. Like, why are you interested in what you're interested in? It's usually more of a, I just liked it. There's something else to it, usually.
Yeah, it's been really rewarding for me to find out people's origin stories just at random and find out more about them.
Yeah, finding out the why for people, I think, is really helps you understand why they're doing what they do, how they take a little bit more, and kind of makes you appreciative of what they're doing and why they're doing it. And especially if it's something that you don't really see it the same way, it's like, well, at least I understand why they see it that way. And it lets a little bit more of a collegial and collaborative efforts, I think.
Yeah, I agree with you. Well, let me back up and ask you the famous dinner question that I ask everybody. I'm going to go out on a limb here and guess you're going to pick somebody sports related. If you could go out to dinner with anybody in the world, could be somebody from the past or from fiction, who would you pick and why?
I have been asked this question before, and it is not sports related. It's family related.
Wow, there you go.
So I would pick my maternal grandfather. I'm a pretty family oriented person. I grew up in a good family. I now have kids, and I want to instill that into them. And I was very fortunate that my dad's parents I was able to connect with. They had a really super interesting story living in Germany, growing up in Germany, and living through the war. My grandpa was forced to fight in the war for Germany, and like beyond the will, right after the war, they moved over here and had my dad. So it's cool to kind of get to connect with them. And on my mom's side, I got to know my grandma, but my grandpa was fought in the war on the American side. So my grandpas actually fought each other in World War II.
Wow,
which is kind of cool. Not directly, but
well, not that you know of.
That's true. That's true. But apparently, like he passed away when I was really young. I guess he got exposed to some things during the war that he could never really recover from, and so talking to my mom, she didn't know him that great either, just because it was he was in the war and then he was kind of sickly after that. But apparently, according to my grandma, he was a fighter pilot for the Air Force. Apparently, he's a pretty well-renowned guy, and my mom has found some interesting kind of articles and things, letters from the Air Force stuff about him. So I just would really like to sit down and kind of know more about his trajectory, his path, what got him into Air Force and flying and all that kind of stuff. It's just kind of a piece of my personal family history that I would really like to know a little bit more about.
That is so interesting. Do you feel like you act as a fighter pilot at work sometimes?
Well, I mean, there's the obvious correlations between the airline industry and anesthesia. So, but not knowing anything really about the airline industry, I have no idea. I'm guessing yes, but maybe
something about checklists.
Yeah, right. Yeah, so maybe there's some of that in me from my grandpa that I never really knew.
So you have spent a tremendous amount of time, and I know from my experience with you that you have a lot of opinions about pain management and how to handle pain in the perioperative setting. When you're thinking about pain as a clinical problem generally, what do you think most anesthesiologists don't get right about it?
I think that there is, I don't know how to put this without being insulting, but there's a lack of understanding of pain. And I think that's healthcare wide. I think it's culture wide, society wide. Pain is very complex and it's very gray. And I explained this to a lot of our trainees that a lot of times in medicine, we like objective numbers. We like diagnoses. We like numbers to point and say, this is why this is happening. You can't do that with pain.
What about the pain scale? Isn't that an objective number?
That was the attempt to put an objective number on pain that has failed miserably, but yet still maintains today. So that's, to me, pain is very complex and it's very subjective. There's a lot of feelings from the patient side that go into it. And then obviously there's a lot of bias from the provider side that goes into it. And I think specifically to anesthesia, I think we deal with a little bit of a unique situation that we don't have patients telling us about their pain, which I present this to our fellows and some of our senior residents, and I say, can the patient under general anesthesia experience pain? And if you look at the definition of pain, they can't, because it's subjective. So they can't. If they can't tell you about it, they're not having it. And then most people are like, nah, it doesn't make any sense. And it's like, I get it. It's more of a philosophical discussion. But I think anesthesiologists or anesthesia providers in general put a lot of their own biases into what pain is, and looking over the drape saying, that hurts, I'm going to give something for that, versus really understanding the complexity of the things that are going into what's causing the pain. And then on the other side is, there's a lot of historical reasons why pain is treated the way it's treated in the perioperative setting. And I personally think it's backwards. I think we use opioids as a mainstay therapy. It's not as strong as it was when you and I were training 10 years ago or even 20 years ago. But I still think that's the crutch that everyone leans on. And I think that we have better alternatives now that can help. And opioids have their role. It's just not as expansive as it is currently being deployed in anesthesia.
So you wouldn't say that pain is the fifth vital sign?
I would not, and I would hope that everyone kind of understands what a massive mistake that was when we went down that path. But
why don't you back up a little bit for our audience and tell that story a little bit?
So you can tell this story in a number of different ways, but I think it was back in the late 90s, early 2000s, there was this push that pain was being undertreated, and that we weren't, as a healthcare community, we weren't taking care of pain with enough compassion and doing enough for it. Now, I believe, and most people think that push was coming from the pharmaceutical industry that had created these great medications called opioids, and that we have this medication that can fill this void that you guys have created in healthcare. And I would argue there was no void in healthcare with that, but it became this forefront of, we were not treating pain and we're not treating patients' subjective feelings of pain well with what we were doing. And so that's what kind of pushed opioids to the front line. And that's what generated the pain scale, the 0 to 10 scale that everyone knows. It didn't take a full comprehensive look at it. And again, I think it goes back to the underlying of why it kind of spiraled the way it did, is because not a lot of people in healthcare felt comfortable with pain. They didn't understand it well. They didn't really know about it. And here came this new shiny thing of, they're having pain. You don't know what to do. Give them this. And it's an opioid, and that's OxyContin. This was the original one. And it works. Opioids work for pain. And so everyone's like, wow, we did it. We did it. And
mission accomplished.
Mission accomplished. We can put our stamp on it. The fifth vital sign is here to stay, and we know how to treat it, and we're going to do it well.
So then what happened?
Then, despite the pharmaceutical companies explaining to everyone that, as long as the patient having pain, there are no side effects, we then found out pretty harshly that there are side effects, and one of the main one being addiction. And that's kind of what spiraled into the opioid crisis that we saw. Going into like the 2007 to 8 is when it really kind of exploded, and when still everyone is very familiar with the opioid crisis now. I think they teach it a lot of medical schools about what it is and what's going on. And, I still think that there is a little bit, going back to what do the anesthesiologists do wrong with pain, is assuming that they aren't part of the opioid crisis problem. If you are pushing or giving an opioid, you're potentially part of the problem. And I don't think people want to admit that or think that. And the steps to get from giving someone a pain medication when they're in pain to them developing an addiction is a far step, and a lot of steps along the way to get there. But the possibility exists, and there are many, many famous examples, from athletes to actors, that have been injured, started opioids, get addicted. Most recent one in the news is Tiger Woods. I just saw today that he's back from his 6 weeks rehab in Switzerland for his opioid addiction that he's got. So started with back injury and back surgeries, and kind of derailed him a little bit. So even the most powerful and the most mighty and the most famous can succumb to this, and we just don't know who it's going to be. And I think that's kind of the tenet I take, is that I look at every patient as a potential future addict, that I don't want to be the one that starts them down that path.
How well do you think that residency does training people to think about pain, anesthesia residency specifically?
I think anesthesia does a far better job than the other residencies that at least I've seen and been familiar with. I think pain is a central component to the ACGME structure. You have to learn about acute pain, chronic pain, regional anesthesia. So I think that there is a good infrastructure of curriculum there. I think kind of one of my gripes with anesthesia training and where I think we're missing the ball on it is the PACU recovery side. I think back in my training, I remember our preoperative kind of training was kind of limited. We did a little bit of it. We had a clinic that we kind of went to every once in a while. It's nowhere near as robust as it is here at University of Cincinnati or at other places I've seen now. So I think our preoperative optimization has gotten better. Intraoperative training's always been spot on. I think everywhere you go, everyone focuses on it, does it well. I've seen people from tons of different residencies that do intraoperative management well. What we don't do is we don't follow these patients. We drop them off in PACU, and that's about the extent of our knowledge of how they've done. And everyone in anesthesia, no matter who you are, lacks the follow through to after they leave the PACU. Like we as faculty get a little bit more experience in the PACU because we get the phone calls or make sure the patients are safe when we get out of the PACU. But even after that, we don't really follow them that much afterwards to see how they do unless we have a particular interest in a particular patient. So I think that is the piece to the pain puzzle that is missing. And I think if people could know fully how each of their patients have done and look back at what they did for those patients pre-op and intra-op and how it set them up from a pain perspective, I think it would really help lock in some of the stuff that we try to teach and train when it comes to pain management in the perioperative setting. And that's what I really like about my position and what we do as far as a pain service here at University of Cincinnati and other pain services around the country is we follow these patients through. Now, that's only not all of them, but we get to follow these patients, see how they're doing and how these things affect them. And it's kind of it allows us to get onto that side better because, when I was training, I always thought, if I can get this patient who's either healthy, unhealthy, whatever, get through this surgery, big, small, and get them through the PACU safely, like I did a great job. And then when I got into fellowship, what I really started to learn and think about is like, can I do more though? Can I make other decisions during those time periods to keep them safe through it, but also set them up for success in their recovery, which I think is a piece that's missing in general, but I think is something that we try to incorporate here, at least from our pain side.
I really liked how you mentioned that pain is gray. And I think from my experience as well, there's a whole bunch of different components, and there's certainly a lot of what we do as far as relieving pain that has to do with expectations and the patient's psychological frame. I wonder what your take is on the non-drug variables for how pain is managed.
I think that's a very undervalued part of this because, as I mentioned, pain is subjective. And so in order to best treat their pain, you got to understand what they're experiencing, how they are kind of experiencing it. And it's a very challenging thing to do. And it's a very uncomfortable thing for people to do too. You got it because you got to get into, let them be vulnerable with you and allow them to explain to you what they're going through. And one of the things I try and do a lot when we're rounding on patients, seeing consults, is just listen to them. And anyone that's been in academic medicine, these patients have hundreds of people coming in and out of their rooms every day, and they all have a particular agenda, right? And a lot of the times, pain is one of the most important things on the patient's mind, but not on all those 99 other people that come in and out of their room. You're there to talk about their pain, or even if you're not there to talk about their pain, let them talk about it. And there have been numerous times where I've had our residents come to me and say, we didn't do anything for that patient, but they said their pain was better after they talked to us. Just because you listened to them. And they said, someone listens. I don't want anything different. I just want you to know what I'm experiencing. And I think it's a hugely undervalued part of pain. And you don't always have to reach for an opioid because their fifth vital sign tells you that their pain score is a 9. And what else goes into it? Like, why is it a 9? Like, what makes you say 9 versus 8 versus 10 versus 20? Like, we've seen it all these scales and all these scores, but like, what is it really that is bothering you? And sometimes it's like, I just want a glass of water. I want to watch my news at night and I can't figure out how to get the TV on. Like, it can be simple things that think about when you're at home and what makes you a little uncomfortable with this. You just adjust and do things, not stuff you can't do in the hospital that well. Sometimes you just need a blanket. Sometimes you need a back stretcher. Somebody needs something simple. And all of a sudden it's like, it's okay. It's better. So there are some pains that like you can't just talk away, or you can't do little nuanced things. You can't do a Sudoku puzzle and feel better about it and distract you from it. And that's where the pharmaceuticals come in. But there's a lot that we can do if we just honestly just took the time to listen to people.
So often when you're doing nerve blocks, or starting IVs, you're doing something that causes some degree of pain that you need to give them before they can be relieved from a larger pain. What's your framework for approaching that with patients? Are there any phrases that you recommend or that you say to them? Do you think that this is going to be a big pinch or a little pinch? Do any of those phrases matter, or what do you think?
So that depends on the patient. So some patients don't want to hear anything. They know it's going to hurt, or you've already explained it. I think a lot of it comes in explaining what you're going to do before you do it. And you lean on them to tell you, like, do you want to know when we're starting? Some patients like to know, like, exaggerate a little bit, like this is going to really hurt. Or some people like, don't tell me it's really bad. Then that's where it's like, oh, small little pinch versus, oh, this might hurt a little bit. Like, or yeah, this might suck. But for nerve blocks, it's pretty easy. Like, this is a very minimal amount of time for discomfort to have a much easier recovery, much better path going forward. And that stuff can all be handled during the kind of when you're talking to them pre-op with them. And, you know, it's part of the thing that we learn as anesthesiologists. You got to build a rapport and get to know that patient and what they're looking for in a short period of time. And I think we all come from varying walks of life and backgrounds, and we all tend to figure out how to do that fairly well. And so I think I don't have any particular go-to phrase. It's just, I like to try to be as positive I can with patients when I can be, and talk about a lot of the positives. I don't try to dwell on the pain that might go into getting to the positive side of stuff.
That makes sense. Focusing on the positive does tend to make a big difference. And I think that I guess reflecting, I think I do a lot of that too.
I think a lot of anesthesia providers do it without really even noticing it, right?
Right.
It's because it's our way of kind of making the patient feel a little more comfortable because we know what kind of the best path is for them, what's going to create kind of the better outcomes for them. And so it's an easier way to kind of get them comfortable with the idea versus if you explain every little detail of pros, cons, negatives, like this could go really, really bad, because we know that everything could go bad in healthcare. But do they need to know about all that? Or can we just talk about, like, yes, there's some risk to this, but the benefits are huge, and we do this a lot. And so try to focus on the positives, get them more comfortable. And a lot of people coming to surgery are more worried about anesthesia than they are surgery, which is wild to me. But
I agree. That sort of rhymes with the talk that I often give to the residents about how to pre-op a patient and how to talk to the patient about risk. I frequently, and not necessarily downplaying it, but I like to compare it to something that the patients already know and are comfortable with and familiar with, which is why I tell patients that anesthesia is safer than your car ride over here. It kind of puts them in a frame of mind that's a little easier for them.
yeah, it's interesting. I've kind of used some of those things before, and it's fascinating to me. I don't know your experience, but like some people are like, I don't care. Like, I ride in a car all the time. This is not my normal Tuesday morning where I get anesthesia, you know? So it's interesting how sometimes those messaging can make sense, but like how it's going to be received.
Well, you have to be careful. You can't tell patients who have just gotten in a car wreck.
That's very true. What brings you here? Car wreck? Well, yeah, this is safer than that. Obviously.
Probably. Okay. I want to talk about something that I have heard in every single resident presentation about a pain plan that I've ever gotten, which is that they plan to do multimodal anesthesia. That is the buzzword. What does that mean? Can you explain to me what the residents are talking about?
I wish I could. I agree. It's a little bit of every time I hear that, I'm like, what does that mean? I always ask it, what does that mean? So multimodal in and of itself just means, two or more of ways to attack something. So you can do multimodal anesthesia, multimodal analgesia. It's interesting. Just last week, we're starting a an orthopedic case, surgery case, and I was talking to the provider in the room with me, and we were talking about how we're going to help, tackle the patient's pain. And the orthopedic surgery resident goes, "You guys can use multimodal." And I'm like, "What does that mean?" He goes, "Isn't that two types of opioids?"
No.
Eh, And I'm like, maybe that could be a way to do it.
Oh my gosh.
So yes, it's a
That's so
buzzword. People
good.
know how to talk about it. They know what to say. Do they know what it means? Probably not. Now, I'll give our residents credit. They know more than that orthopedic surgery resident, which is what it is.
Wow.
But I think the interesting thing about multimodal is that while it's great on the surface, like we're not opioid centric for our analgesic plans as we used to be in anesthesia. I think the problem with multimodal is a lot of people have either they're swung the pendulum all the way to the other side. Like, I'm not going to give any opioids, so therefore I'm going to give you every possible pain medication I have in this drawer, and there's no real thinking behind it. Like, what's the goal? What are we trying to do? And it kind of goes back to what I think we fail at anesthesia a lot is we just assume there's going to be pain. Like, we have to be doing something for pain during surgery. Now, everyone knows that surgery is pain. Like, it's going to be painful. That's why we exist in anesthesia, because patients can't tolerate the level of pain without us being there. But it takes me one of my favorite teaching moments when I'm working with residents in the OR, and I ask, like, okay, take away all nerve blocks, everything else you've done in pre-op. In the OR, what's the best thing you can do for this patient's pain? And they start rolling off these things, and I'm like, have you ever thought about not giving them something might be the best thing for them? Like, not exposing them to opioids in the OR if you can avoid it. And so that's kind of my philosophy in anesthesia is, like, though everyone likes to get the train tracks anesthesia, you want to have the easy, even vital signs. You want to have boring anesthesia. I'm assuming everyone likes that. I like that. Maybe like Dr. France here may not like that. He likes a little bit more of the chaotic, crazy stuff. But I'm like, that's finding the right depth of anesthesia for that patient, where you don't have to chase vital sign changes or anything like that. That means that they're not experiencing a lot of pain, a lot of stimulus, and things like that. So sometimes you get to those perfect depths of anesthesia, you don't need to give them anything for pain. Just let the anesthesia do the job for you. And so that's where I think multimodal anesthesia can be helpful, when you add a couple different elements to increase the depth of your anesthetic without causing a bunch of hemodynamic variation. Opioids can fit into that. We do that with neurosurgery, spine surgeries, and but you can also do it without it. So I think the multimodal is a great concept, but it's kind of pretty ill-conceived in what it actually means and how to execute it.
There are so many things beyond opioids: ketamine, lidocaine infusions. Precedex has certainly come into vogue in the past few years. Gabapentin, Celebrex. What's overrated? What's underrated? What do you think?
I think now I speak kind of more of our practice here and what I see here. I think ketamine's a little overused for what it's worth. I don't complain about it, because if someone's going to grab for a little bit of ketamine over a little bit of fentanyl, I prefer that for a patient. I think that's better. When you're thinking about long-term kind of recovery, kind of getting through the PACU and kind of better setting them up for there. So I think in the current landscape, I think the gabapentinoid class of medications actually has a role. I know that there was an article that came a couple years ago that said it shouldn't ever be used for acute pain, and a lot of people have grabbed that. But it goes to the lack of understanding, what is that drug doing? What are we doing with these medications? And I think it goes to, people have jumped on the multimodal, and you're right. There's a ton of options available for people now. Like, you don't have to just grab for an open. I think that's great that people are doing this. Is why I love working in an academic environment to teach the residents about this. But if you're going to grab the ketamine, what are you trying to do with that medication? You're grabbing Robaxin, you're grabbing Celebrex, you're grabbing gabapentin. You're doing these things. What are you trying to accomplish? What do you really want to come from that? And what are you actually treating? So pain, there actually is pathophysiology to pain. So what is causing this person's pain? Is it nerve-related pain? Is it inflammation? Do they take a bunch of opioids? Are they opioid tolerant? And so therefore you need to work on, maybe a little bit of a different mechanism. So there's a lot of different options out there, but knowing what you're going to target, instead of just shotgunning it all and blanketing it all, which is some people tend to do, I think it's best to tailor your approach to each individual patient. And that allows you to get a little bit more sophisticated with your medications, but also when you're treating the actual things that are going on, you have less risk of the bad side effects coming when you just kind of shotgun and give everything.
So let's say you've got an opioid tolerant patient coming in for surgery, and it's somebody who is chronically taking massive amounts at home. We've seen this plenty of times, each of us. Uh, what what framework would you want one of our residents to approach that patient with?
They need to. I think everyone needs to come from an understanding of what does that mean. What is that patient's body? How is it going to react to pain, to a painful stimulus, to pain, any pain medication we give them, and which of our options are best suited for those patients. So, when patients are opioid tolerant, taking a lot of opioids, they need way bigger doses than most people are in healthcare comfortable giving them. We get a lot of consults on our pain service saying, "Hey, we need help controlling this person's pain. We don't feel comfortable going up higher on doses." I'm like, "You're giving them a tenth of what they get at home, so of course they're going to hurt. Like their body's used to it." And so we see the anesthesia. And what I find fascinating from my standpoint is, I have someone in that situation. You can give them opioids, but it's not going to have the effect you're going to have it. So you're going to have to lean on your multimodals. You're going to have to lean on your other medications. And I think that freaks some people out sometimes, because I want to be able to give my fentanyl and Dilaudid and have the patient be comfortable, and it's not going to happen. And so knowing, again, all the different medications and options you have, how do they interplay with each other? That's one where I've seen those patients and ketamine is not part of their analgesia plan. I'm like, that doesn't make any sense to me, because that's the best medication you could give for that patient. Then no one really thinks about methadone in those patients. Like, that's a great option. Like, there are so many options. Like, I don't know. Like, maybe it's just my training or where I was, but when I was a resident, I feel like we didn't have all the options. Precedex was too expensive. Ketamine was not really available. Um, Gabapentin wasn't given. Celebrex wasn't given. I don't know if it was cost or whatever. Like, I remember IV Tylenol was like the vogue thing, but it was too expensive. So we're not supposed to give that. So it's like, we're giving Tylenol and opiates all we really had. Right? And now, you think about all the options we have, like, you have a lot of things you can do. And those patients that are opioid tolerant or are on any kind of opioid use disorder medications, that's where more of a shotgun approach might be beneficial. You got to try to attack every different receptor pain pathway you can find, try to help them, because you're our main gun that we have for analgesia is opioids, and they just aren't going to be as useful as they are for opioid naive patients.
So a lot of times you find yourself advocating for doing more nerve blocks. That makes sense. You're the director of regional anesthesia.
I hope I am.
And I think you do a great job at it. But sort of what I want to know is, what are these conversations that you're having with surgeons to advocate for those nerve blocks?
So it depends on the surgeon. So I treat my relationships and communication with surgeons kind of like with patients. Like, I need to understand where they're coming from. And I kind of had an aha moment about 2 years into being faculty. I was actually teaching a cadaver ultrasound course at Walter Reed, University of Maryland. And they had a guest speaker, a surgical oncologist, and he was going over how he appreciates help with pain and anesthesia and all these different things. And then it got to the Q&A part, and my old fellowship director at the time, was an older, kind of a little bit more aggressive individual. He tried to pin him down and say, "Why don't you like NSAIDs? They're great. Why don't you like epidurals? Like, they're great." And the surgeon just admitted it and said, "Pain's not number one on my list for this patient. It's not my number one priority. It's not my number one concern." He goes, "It's maybe not even my top 10. I'm worried about, can I get him through surgery without blood loss? Can I get him without infection? Can I not have their anastomosis leak?" So to me, that was my thinking. Like, I'm coming at it as like, all I care about is pain. I want to do everything from a pain side, from the regional side, like block side. What can I do to help this patient? I'm like, I have the best block for this case. I'm going to do it. And I go to the surgeon, like, "I don't want that." I'm like, "What's wrong with this person? Do you not care about this pain? Do you not care about this? Do you not care about, them getting opioids and all these things that I care about?" And that's down on their list. They would like to have that happen, but they got to think, can this patient walk after surgery? Can they do this? Can they do that? So me really trying to talk and understand what are their priorities, and then how can we fit our regional anesthetic into that to not interfere with how they are trying to get their patient to recover the best they can for their surgery. And so that's where I needed to have that aha moment to get rid of this. Like, I need to get away from this, be a pain purist. Like, I'm going to do everything exactly perfect for everyone's pain. but fit into the actual healthcare system, and how does this help everyone and everything get the patient to recover the best and have the most chance for success after surgery?
I had an experience with a surgeon who will remain nameless that I thought was really illuminating for me when they were injecting local at the end of the procedure, which I really appreciated by their surgical site. And they asked for local, and it got drawn up for them. And the nurse in the room asked them, "Oh, do you want it with or without epi?" And the surgeon said, "Without." And I was confused because what I know of epi is that it tends to densen the block and make it work better and last longer. And I thought about it for a second. I was a young attending, like second or third year. And so finally, I just asked the surgeon, I was like, "Can you help me understand why you didn't want epi as part of what you're injecting there?" And what he said really stuck with me was, "I don't know. What's the difference?"
I was hoping that was going to go a different way, but no. Okay.
So sometimes it's not necessarily that they have a master plan in mind, or that they sort of have thought that hard about it and they have a specific preference. It's just that they are given two options and they pick one.
Yeah, that's the other side of the relationship coin. Is I need to be able to explain what we're trying to accomplish. What's my goal for this patient? Why am I doing this? And there are some surgeons that are very interested in learning and understanding why we're doing what we're doing. Like some would answer that question, and go, "What's the difference?" And you would explain the difference. They'd be like, "Oh, okay," and maybe make a different decision. Like,
And I did.
yeah. And did they make a different decision?
They did.
There you go. And then there'd be others that would say, "Why are you asking me that question? This is my decision."
Right.
And so, it's kind of interesting in anesthesia where we are a consultant in every aspect of it. We don't bring these patients to the OR. We don't do any of this. So we need this relationship with the surgeon. And some are a lot more collaborative, a lot more willing to have discussions and have a shared common goal. And others are more of, these are my goals. You fit around them or you make them work. And the nice thing about regional anesthesia is that we have a lot of options available to us where we can fit in. And sometimes I don't like it. I don't think it's the best bet for some patients to be doing some of these things, but it does allow them to get something, like you're saying, injecting local anesthesia, better than nothing. So if we can get a little bit of a little extra analgesia from these things, then I'll fit within the system and we'll try to do the best we can and work with the surgeons on what their goals are as well. Because I don't think about the post-surgical outcomes that they're thinking about. So if we can mesh it all together, I think we give all these patients the best chance going forward.
I don't do as much regional anesthesia as I did in residency, of course. I did lots of blocks back then. I got pretty facile. I still feel comfortable doing basically all of the main blocks. But I wonder if you can comment on some of the newer types of blocks that have come into vogue. What do you think's overutilized? What do you think's underutilized? What's the landscape look like in terms of the new nerve blocks?
So the newer thing in regional anesthesia is fascial plane blocks. It's again trying to fit regional anesthesia into the surgical outcomes that surgeons are desiring, and honestly trying to catch up with surgical advancements. A lot of the minimally invasive, robotic, laparoscopic surgeries, these patients aren't in the hospital for a week or two like they were before, where you could put an epidural in, manage it for a couple of days, manage their pain for a couple of days. They want these patients out in the hospital in 2 or 3 days. So how do we fit into it? And so a lot of it has been fascial plane block related. And the reason why it's fascial plane block related is because you minimize your side effects. So I think epidurals are great. I think they're one of the more underutilized things, especially here at University of Cincinnati, but I know other systems have moved away from them because you have to worry about side effects. You have to worry about bleeding in and around the spine. You have to worry about blood pressure issues with the sympathectomy of it. I think paravertebrals are great, but you still have some of those issues and a little bit more of a challenging block. So people have gone to some of the newer blocks are erector spinae plane blocks, PEX blocks, serratus anterior blocks. There's always been TAP blocks, been around for a long time. I think tap blocks are by far the most overutilized block that doesn't do a lot of anything. I think that's what has spurred some of these newer blocks of fascia plane, because if tap blocks are doing really well, we wouldn't be looking for replacements of it. So we don't do a lot of those here because I just don't believe they're adding to any benefit to the patient. Now, some of these newer blocks, the interesting thing with the regional anesthesia is that someone comes up with a new block and they put out a paper basically saying, here, look what we did. The patients look like they're doing better, and people just start doing it. The most recent example is something called a PENG block, which was designed for hip replacement surgery.
Yeah, I think I've seen something about the
PENG. Yeah, pericapsular nerve group. It doesn't really fit or make sense, but the guy who developed it was Dr. Peng, so he had to make that work. So it was just like, hey, they don't want us to do ephemeral nerve blocks. They don't want these patients weak. They don't want us to do a fasciolaca block anymore because they might get weak because you're going to hit the femoral nerve. So why don't we just go deeper and just put local all right by the hip joint itself? And he described it, and everyone started doing it. And now, 3-4 years later, studies are starting to come out. Let's do randomized controlled trials of this and, placebo, whatever. It's not really faring too well against saline or placebo. So, I made that mistake early in my career when the erector spinae blocks came out. We started implementing them for a couple of our surgeons because they didn't want to do epidurals for various reasons. And we didn't see very good clinical success for them, and we slowly weaned them out. And then a couple years later, when studies really started to come out with them, they started to bear out like maybe this isn't it. And so there's still some trials out about some of these, about maybe refining the technique, but there's a big push to do these fascial plane blocks, get something new, get it out there, let everyone start doing it, and then we'll figure out is it useful or not. And kind of a frustrating area to be, because as the regional anesthesia director, I get asked a lot from various leadership people and trainees, like, why aren't we doing this new thing? It's like, I don't know if it works, and I don't want to be the one experimenting on patients without it being an actual study. Like, so we can set up an actual research study and do it, then yeah, that makes sense. But it is interesting seeing how all these things come out and then how they're implemented, and then we wait for the evidence to show whether it's going to work or not.
I couldn't let you get away from here without getting your best hot take on everyone's favorite drug to argue about, which is Exparel. Can you talk about first maybe explaining what Exparel is for maybe some of our medical student listeners, and then give us your take and maybe what the broader takes on it have been?
So Exparel is technically liposomal bupivacaine. So they take bupivacaine, which is a very old local anesthetic that is still used commonly today, and they put in these little liposomes, and they are supposed to kind of dissolve over time and release the medication at a kind of a consistent rate over the course of 72 hours. And so it's billed as a long-acting local anesthetic. So now most of our single injection nerve blocks last anywhere from 12, 18 to 24 hours. Enough for some surgeries, but not enough for other more painful surgeries. And so a lot of people in the pain world think if you can get 3 days of pain control with a nerve block, or renal anesthetic, reason why we place catheters for some of these patients, that'd be the holy grail of regional anesthesia. You would never have to put a catheter anymore. You can never do that. So when it came out, they did some small studies to show, again, can this be used? And like, yeah, it can be used, and it has numbing medicine, so it can numb things. And so it just, the company that runs Exparel is a brilliant company. They marketed it well. They knew where to hit the trigger points. They knew how to get surgeons mostly on board, because they go to the surgeon and say, you don't want to deal with pain. You don't want to deal with opioids. You don't want to deal with these pain catheters or these pain people hanging around your patients. You just inject this. There'll be 3 days pain-free, and then you don't have to worry about it. And people sunk their teeth into it, and it became a very, very popular medication. It's been used. It's very expensive still. To get a vial of plain bupivacaine is about 30 cents, and a vial of Exparel is about, I think, $350. So it's a pretty big difference. And over the last 2 to 3 years, maybe it's been a little bit longer than that, some studies have started to come out that were not funded by the company that makes Exparel, comparing Exparel to plain bupivacaine, and the results have not been good for Exparel. It is, at best, it's been equivalent, but some have said it's worse than actual plain bupivacaine. And whenever I've been around their representatives, they don't like it because I explain the math to them, and it doesn't make sense to me. So to explain it to people in the simplest terms is we inject around 150 milligrams of plain bupivacaine in a typical nerve block. There's 266 milligrams of bupivacaine in Exparel. And so if you do the math of 266 milligrams of bupivacaine over 72 hours, and if it's released continuously at a slow rate like they say it is, you're getting not enough local anesthetic to the nerves to make a difference. And when you look at the math, it'd be like us putting a catheter in and running it at less than 1 cc an hour, which everyone, if you look at it, it's like that doesn't spread around, doesn't cover the nerve as well. So that's why it doesn't work. It's a cool concept, and it does work the way it's supposed to, but problems when they're doing their initial studies, they tried to put more bupivacaine in the liposomes, but they had issues with the animal subjects not making it because of local anesthetic toxicity. Because if it doesn't release in a consistent fashion, you release too much, you're going to get toxicity. And so that's 266, the most they could get in there safely, and it's just not enough to achieve the goal.
You're going to make it really hard for me to get sponsored by Exparel for this podcast.
I think they'd still sponsor it. They're looking to sponsor anything they can get their hands on. So,
well, so far I haven't run any specific ads on the podcast, but advertisers, if you're listening, if you would like to give me money,
we're interested.
Then please feel free. In general, the opioid pendulum has definitely swung away from opioids. People have realized that there's the opioid crisis, and our residents, and I think residents sort of across the nation, are starting to understand that opioids aren't the way forward and are coming around to your point of view, maybe a little bit more slowly than we would like. However, do you think that it might be swinging a little bit too far? Do you feel like maybe we're not treating acute pain appropriately in some of these populations?
I think possibly, yes. I think I don't like to have anyone have the concept of if you're not giving an opioid, you're not treating pain well. That's not true. I personally think the pendulum in anesthesia specifically has not swung far enough away from opioids as opioid centric. I don't know the exact percentage, but I would say probably 20-25% of cases should get opioids. The other 70-75 should not. Like I think that there's a lot of that you could get because we have so many options nowadays. And now this is just pre-op and intra-op. I think we can get them through. And if we deploy all of our options that we think make the most sense for that patient, that surgery, and they wake up and they're in recovery and they're having pain, then you can use a small amount of opioids, and that usually works really, really well. And you don't have to use a ton, and it usually helps get rid of their pain very well. So I think that I think there are some particular individuals that have become, the term is opioid phobic, where they're not going to give anyone an opioid no matter what. And I think that's where you can get yourself into problems. So as long as you don't have that, you understand that opioids are one of the weapons you have to combat pain. It's just not the main one. And I like to view, like from my position, I use local anesthetics, nerve blocks as my main weapon. That's how I'm trying to attack pain. But if you ask me, if you took away one other option, I'm fine. And that's where it's like, if I tell certain anesthesia people, like providers, like you can't use opioids, they don't know what to do. And that's a problem. Like to me, that's an issue. I had an attending in residency that would, every time we worked with them, would just say, you can't use this medication today. How are you gonna get around it? And most of the time it was fine, but then like took away propofol. I'm like, it's like, that's a big one. But it's like, you imagine like, you can't use a paralytic today. How are you going to get through these cases? In some cases you can, some like that's going to be harder, but it's just, I like to think of that in the pain sense. Like if I can't, and that happens, right? You get an elderly patient, you get, certain patients, on an opioid, diversion therapy or something, you can't give up. They're going to take classes of analgesics away from you. And sometimes surgeons and surgical techniques, like I can't do a nerve block for it. What else am I going to use? And so, as long as you're always thinking about their pain and trying to do something for them, you're not going to undertreat them. But I think there are some people that have gone too far too scared of opioids, but don't know enough about all the other alternatives that they will be undertreating some people's acute pain, which is the number one thing you can't do, because that will lead to potential chronic pain.
Let's talk about your fellowship a little bit. Who's it for? Who's it not for?
So the main reason why I would recommend anyone do a fellowship in regional anesthesia acute pain is you love it. You want it to be a part of your life. Um, Regional anesthesia, everyone does it. Every anesthesiologist can do it, should do it. I'm a firm believer in regional anesthesia. As long as you can do it safely, do it. The more nerve blocks and injections we can do, the best. There is a whole nother layer of regional anesthesia acute pain management that the fellowship gets you to. So we've had plenty of really brilliant CA3s that have like killed it through their whole career as residents here for regional anesthesia acute pain, and there's still layers I can get them to. And so if you have that passion, desire, I want this to be a key central point of my career. I want any practice I go to, I'm going to be the go-to person for blocks, the go-to person for pain. I want to set up an acute pain service. I want to run a surgery center. I want to have leadership opportunities. That's who should be doing a fellowship in regional anesthesia acute pain. There's no more money involved with it typically, which some of the fellowships can kind of hang their hat on. There's no like preferential scheduling you get from it, which some other specialties can get, subspecialties can get. So those are the people that I'm looking for the fellowship. People that are genuinely just interested in learning that deeper level of why do we do what we do and how do you do it. And honestly, if you think about your career and if you think like, oh, I can go take a job where if I do blocks, great. If I don't care. Probably don't need to do a fellowship. If you're thinking like, I can't have a job where I don't do this, then fellowship's probably the best spot for you.
So how do you take that strong CA3 and take them through that year of fellowship and turn them into that person you're talking about?
So understanding everything that there is to know about regional anesthesia and acute pain sets that individual up to have those conversations with the surgeons that we talked about earlier. Allows you to better explain what you do, how you do it, and how you fit into their system and how you make it work. So I had a conversation with one of our colleagues a couple months ago. We have a new orthopedic surgeon. He wants to take a little bit of a different approach to some nerve blocks just because he's in his earlier career. And the question I got from our colleague was, why can't he just do the standard of care that we do here? I'm like, because we don't do standard of care here. I've used my position and my fellowship training, my knowledge base to fill in these surgeons' ideas of where we should fit into their life as orthopedic trauma surgeons. And so we do way more blocks in regional here than anywhere else. And it's because I've been able to use that. So that's how I was able to set up and build our pain service basically through that. And so the fellowship starts with building that knowledge and building that confidence in that you know this better than anyone else. And then you have to actually be able to do it, right? So we have our residents here graduate with hundreds of blocks, right, over the course of 3 years.
Very strong.
Really good experience. They get exposure early and late. They get exposure throughout. But I still think it's not enough if you want to be the person. If we're gonna plop someone into an orthopedic surgery center that's going to have 8 rooms and you need to do all the blocks, spinals, everything, keep it efficient, keep it effective, keep it flowing because you can't have PACU slowdowns. You got to have the reps and you got to have the familiarity with how to do that. And so we get the knowledge and we get the skill down for the fellows, and that sets them up to be able to produce, but also to be able to set up and communicate to the surgeons how they fit into that mold. And then from my side, which I very much underappreciated that I got from my fellowship, is how do you also deal with administration, and how do you explain how you fit in and why are we here? Like, what are we doing? What value do we provide to the health system? And because a lot of them don't have the medical background to understand everything that's going on, but you can use your knowledge and understand a little bit more where they're lacking their knowledge and fill those gaps to then have them say, you are providing a very valuable service. That's great. How can we help you? And how can you get involved in stuff? And so it also, having that fellowship training also gets you into positions where you can be on these committees and working with administration and leadership to try to figure out how to best of course the health system, but also to the benefit of you and what you're trying to do and how you're trying to help your trainees and patients.
This has all been a really great conversation that I appreciate, but I want to wrap up with my final style points question. What are your personal style points or points of personal preference that have helped you build a pain service, that have helped you succeed? I'd love to hear them.
So the number one thing that comes from my mind that it took me a while to learn through my career is communication. You can never, ever over communicate. And, having toddlers, I've learned a lot from them. You have young kids. When they may not know how to communicate, but when they want something, they make sure you understand that they want something, right? When they want to get a point across, they do it, but they communicate it. And if you're not understanding their first form of communication, they try a different one, and they try a different one.
A louder one,
typically, right? That doesn't always work in the professional healthcare setting, as I've tried. But communication is so important, and I use it in my personal life. I use it with my wife, my kids, my family, with my friends. Like communication, and communication is a two-way street, right? It's like I need to be expressing to my views and what I'm trying to get across, what my goals are, but I also need to be hearing whoever I'm working with, what their goals are and how it fits. And doing that in a rational, calm, patient manner really helps build relationships. So communication is the key point that starts. Then you build relationships, and this. When you have a relationship with a colleague in anesthesia or a surgical colleague or whoever it is, it makes life so much easier, right? You're like, hey, buddy, like I remember the story. I went golfing with one of the orthopedic surgeons, right? Had a great time. It was cool. Got to see him outside the hospital. Literally like 2 weeks later, we're doing a case together. We're finishing the case. He happens to be walking through. Patient, all of a sudden, we're waking up not doing well. Patient happened to get a spontaneous pneumo randomly. But I just be able to look at him. Hey, we got a problem here. He instinctively just got on the phone and called our ACS trauma backup and said, hey, I need you to come to this OR. And by the time he got there, like, hey, we got a pneumo. It was 5 minutes from when I told him we have a problem here. We got an X-ray. They put the chest. And the patient was fine. And it was just like, it was easy because I had no problem to say, hey man, like this is what I need. I need some help. And he knew kind of, it's just, it makes life so much easier to ask for help, to understand where you're going, have communication. So starting with that communication, building relationships, it makes life so much more enjoyable, so much better, and so much easier for everyone.
So really, I suppose everyone can learn from you is to be more of a buddy.
Buddy with an E, yes.
Brad, thank you so much for joining us.
Thanks for having me on. This was fun.
Well, that's it for this month's episode of Style Points. My thanks to Dr. Budde for coming on and giving us his perspective. If this episode didn't teach you everything you wanted to know about acute pain, well, you'll just have to apply for his fellowship. If you got something out of this episode, the single best thing you can do to help other people find the show is to leave a rating or a written review. It really does work, even if I pretend that I don't look at them. As always, you can reach me at stylepointspodcast@gmail.com, and I'm still happy to mail you a free Style Points sticker for your water bottle. Take a deep breath, open your eyes, we're all done.